Hello everyone, I'm Dr. Magesh, one of the junior residents here. So this is a crash course, which will be a brief overview about advanced life support, ALS. Mostly we will be seeing about the guidelines given by European Resuscitation Council. This session is a part of the junior residents teaching series. So first, the statutory warning. This is just for educational purpose and to give an awareness. It is in no way an alternative to do ALS or ACLS courses. You should promptly do that if it's pending. Try to renew your ALS ACLS courses. So why ALS? Sudden cardiac arrest is the leading cause of death. In fact, it is the third leading cause of death in Europe. This cardiac arrest can happen anywhere, in hospital as well as out of hospital. That is the in-hospital cardiac arrest versus out-of-hospital cardiac arrest. The prognosis differs widely between the in-hospital and out-of-hospital cardiac arrest. And in-hospital cardiac arrest is supposed to be having a good prognosis. So all these resuscitation courses, BLS, ACLS, and ILS and ALS, their main aim is to get back the spontaneous circulation so that the post-resuscitative care can be taken. All these resuscitative courses, they depend on this main concept called chain of survival. What is this chain of survival? So even before the patient goes into arrest, we should be able to recognize the situation which could prompt the patient to go into arrest, and we should call for help promptly. Once the patient goes into arrest, early CPR is indicated so that you can buy sufficient time where the blood circulation can reach the heart and brain. Early defibrillation is essential for shockable rhythms like pulseless ventricular tachycardia and ventricular fibrillation. Once the patient gets a spontaneous circulation back, post-resuscitation care should be started promptly to restore the quality of life. So prevention is always better than doing the damage control. So how do you prevent a patient getting a cardiac arrest? When you feel that a patient is deteriorating or his vitals is deteriorating, in European countries and UK, they have something called modified early warning scores and early warning scores. So when the patient deteriorates and their vitals uh, is modified early warning scores. So when the patient deteriorates, there will be proper guidelines as to how to escalate, on to whom to escalate, and when to contact the ICU team and when to shift the patient to ICU, all these things. So what do you do when you feel that the patient's vitals are deteriorating? You follow this ABCDE approach. It might seem simple, but we don't follow this strictly. So in this ABCD approach, first you examine the patient's airway, breathing, circulation, and look for any disability, and you expose the patient's whole body and see if there are any uh, things that could be any reversible causes for his deterioration. You do the appropriate intervention to achieve a goal. So individually, we would see what these comprises of. In airway, you see if the patient's airway noises are normal. Sometimes if the patient might be having a stridor, or if the patient is having anaphylactic reaction, his airway might become edematous. So what you do in those situations is you do suctions if there are any secretions to remove, and if there is anaphylaxis, the first thing you do is you give adrenaline IM injection. These things try to get a patent airway. In B, you look for you listen to the breath sounds, and you see if the chest is symmetrical by looking at the trachea, and if there are any absent breath sounds, and if the jugular vein distension is there. You do these things to rule out if there is any pneumothorax or if there is any severe collapse. In breathing, you also assess the saturation of the patient and give sufficient oxygenation to the patient. In C, you look at the circulation, you look at the heart rate, blood pressure, and capillary refill time. If the patient is having a hemorrhagic shock, all his blood pressure and his heart rate would be increasing, blood pressure would be decreasing. In these cases, in the C is where you obtain an IV access to give sufficient IV fluids to maintain a BP saturation of more than systolic BP of more than 100 mmHg. Then you whenever you feel that when you're coming to the next thing, you're coming from A to B or B to C, you should go back and assess if the thing which you are done in A is sufficient, or you need to do anything else to maintain a patent airway. So you would always go back to the first thing and come in that order. You should never skip the order. Say if the patient is having a pneumothorax, if you skip B and go to C, there wouldn't be any, uh, the cause is still there. So the patient wouldn't improve. In D, you look at the neurological function of the patient, which you can assess through AVPU or GCS, and you would look at his pupils, and you also check for his blood glucose levels. If there is hypoglycemia, you can use the glucose infusion. And if there is pinpoint pupil and if you're suspecting opioid toxicity, you give naloxone. And in exposure, you expose the whole patient with respect to his privacy, of course, and you see if there are any rashes or if there is urinary obstruction, and if you want to see the urine output of a patient in a septic, and you can do ABG to look for lactates. These things you do in E. You have assessed the patient. So what do you do now? You have to tell this to the concerned person who would be taking care of the patient in the next step. You do this through something called S bar. The idea of S bar is to convey the information promptly in a concise manner. In first thing for us is the situation, is who are you, where are you, and what are you conveying. And in the background, you will be telling about history. And in the assessment, what you assessed in the previous slide, the A, B, C, D, E, you will be telling about it, and what you're recommending to the concerned person. For an example, say, I'm Dr. X, I'm calling from the medical ward regarding a patient Y who I think is having sepsis. In the patient history, you would be telling patient Y was admitted with pneumonia with 5 days of fever. So on assessment, he is able to talk a few words. His saturation is 85% with 15 liters of O2, and the circulation, his BP is around 90 mmHg after giving a 500 ml fluid bolus. And on exposure, there are some rashes. So I think the patient is in septic shock. We had taken the appropriate cultures and started him on IV fluids and IV antibiotics. We promptly need you to come and assess this patient. This is the structure of S bar. This can be modified to all the diseases that you come across. So the patient has gone into cardiac arrest. What do? If you have witnessed the patient collapsing, or if you have the patient is not responding, the first thing you do is you call them and tap on the shoulders and say, hello, are you all right? Are you all right? If they are not responding, and if you're the only person on the scene, the next thing you do is you call for help. As a single person, you won't be effectively doing all the things. You should call for help as soon as possible. Once you call for help, then you look, listen, and feel. So in the top right corner, you are seeing the patient. First, you should look at the chest rises, listen to the patient's breath sounds, and simultaneously feel his breath on your cheeks. And if you're not a lay person, and if you're a medical professional, you can simultaneously check for the carotid pulse. All these things, looking for the pulse and looking for the chest rise, should take place less than 10 seconds. So if you're feeling, if you're not feeling a pulse, and if the patient is having a agonal gas, you start the CPR. What is an effective CPR? The chest compression should be at a rate of around 100 to 120 compressions per minute. This could be taken care of by having a metronome, which would be that you can set it in your phone to 110 compressions, 110 per minute, and just follow the beats and give chest compressions. After every 30 chest compressions, you give 2 breaths. This is the 30:2 ratio which we follow. In children, it would be 15:2. And say if the reason for the patient having arrest is like a respiratory arrest, if the patient has drowned, first you give rescue breaths and then start the 30:2 ratio. The chest compression should be at least 5 centimeter deep, and it should not be more than 6 centimeter deep. There should be as minimal interruptions as possible. So while you are doing this, and if if AED is available, you get the AED, connect, and follow the instructions. So while connecting the AED, also you should try to do the chest compressions, and there shouldn't be any interruptions. Once the AED is connected and it tells the rhythm is being analyzed, you should step out and wait for the rhythm to analyze. And if it's a shockable rhythm, it will give an automatic shock. You can step back. Once the shock is given, you should immediately start the CPR without waiting to do a rhythm check. After 2 minutes only, you should do the rhythm check. So what's the proper technique to do a CPR? So you should, with interlocked fingers and heel of your one hand over the bottom of the sternum of the patient, the wrist, the elbow, and your shoulder should be in a vertical line, and the movement should come from your hip. In this way, the person doing the CPR wouldn't get tired very often, and it would be an effective CPR. You should obviously not do what Mr. Bean is doing here. So the algorithm, advanced life support. So you're seeing a patient unresponsive with absent or abnormal breathing. The first thing you do is you call the EMS, is the emergency medical services, or the ambulance. Or if you're in a hospital, you call the respective resuscitation team. Here we have the code blue teams. So once you call them, you start the CPR at a ratio of around 30:2. In hospitals, you can afford to have ECG leads. So with that also you can assess the rhythm. So you're having a shockable rhythm. What are the shockable rhythms? Ventricular fibrillation and pulseless ventricular tachycardia are shockable rhythms. If the rhythm is shockable, you give a shock and you immediately resume the chest compressions for about 2 minutes. After 2 minutes, you should go back and assess the rhythm. If the rhythm is still shockable, you can again give another shock. Like this, after 3 shocks, you can after 3 shocks, you can give amiodarone for these shockable rhythms. And if the rhythm is non-shockable, which is a pulses, electrical activity, or asystole is seen in the rhythm, then you should immediately resume the chest compressions. Throughout the resuscitation, after about 3 to 5 minutes, you can give adrenaline to the patient. So what are the cardiac arrest rhythms that we commonly see? First one is the ventricular fibrillation. This is an irregular rhythm, and the rate would be around more than 300. And the next one is pulseless ventricular tachycardia. This pulseless ventricular tachycardia is a regular rhythm, which you could see in the monitor. So these two rhythms are shockable rhythms. Like I told, the automated external defibrillator, you give a shock on its own. If it's a manual defibrillator, you should assess the rhythm and give the shock. If it is asystole, there won't be any QRS complexes or P wave visible on the rhythm. This pulseless electrical activity doesn't concern to any rhythm as such. Any rhythm without a pulse is considered as a pulseless electrical activity. The different types of defibrillators are these AEDs, automated external defibrillators. These would be available in public places, in airports, in bus terminals, and in public places. This manual defibrillator will be available in a hospital. Most of the manual defibrillators are biphasic, which means that the shock, once you deliver the shock, halfway through the shock, the direction of the shock changes. So these biphasic defibrillators are more effective than monophasic defibrillators, and these are in initial shock energy would be 150 joules. For the next shock, you would increase it to 200 joules. What is the extra step in ALS compared to BLS? So in ALS, the proper personnel would be available who would be trained in getting an advanced airway. These advanced airways could be either supraglottic airway, but if the proper expertise available, invasive ventilation could also be tried. When you do this advanced airway, you can also use the waveform capnography, that is the ET, measuring the ET CO2 levels. And in this ALS, once you obtain an intravenous access, you can start giving the adrenaline and amiodarone respectively. The main thing about these resuscitation is that you should always try to identify the reversible causes and treat them. So if you treat the reversible causes, the patient would get back into sinus rhythm. Now we'll see what are the reversible causes that can be treated. You can remember it by 4 H's and 4 T's. The 4 H's would be hypoxia, hypovolemia, hypo or hypokalemia, and hypo or hypothermia. If the patient is hypoxic, you give oxygen supplementation and try to maintain his SpO2 more than 94%. If the patient is hypovolemic, you give IV fluids, mainly crystalloids, and try to maintain systolic BP of more than 100 mmHg. If the patient has had a hemorrhagic shock, it is advisable to give a blood transfusion as soon as possible rather than just giving crystalloid fluids. The most common electrolyte abnormality to induce the cardiac arrest is hypokalemia. So these causes should also be identified immediately and treated. The other common cause is hypo or hypothermia. These causes are not so commonly found in India, but in temperate countries and in Arabic countries, these hypo and hypothermia are very much common. The four T's are the thrombosis, namely coronary or pulmonary thrombosis. If there is a massive pulmonary thrombosis, it could induce a cardiac arrest. So how do you find this coronary thrombosis and pulmonary thrombosis? If a person with sufficient experience is available, a bedside focus can be done simultaneously when a CPR is going on. This in no way should interfere with the CPR or postpone it. If the patient is in a cardiac tamponade, with bedside ultrasonography, it can be decompressed. And in tension pneumothorax, needle decompression is recommended first line. Toxins are rare causes of cardiac arrest. The patient is getting a spontaneous circulation and his rhythm has reverted back to sinus rhythm. What do you do now? The first thing is you should look for any cardiac cause for the cardiac arrest. If you're suspecting cardiac cause, you would take a 12-lead ECG, and if there is ST elevation, promptly the cath lab would be informed and the patient would be taken up for coronary angiography. If you suspect the cardiac arrest is not the cause, the other causes should be explored, and the patient could be taken up for CT brain or CTPA. After this, the patient should be admitted in an ICU. In the meantime, his airway should be secured with an advanced airway. Breathing should be proper with maintaining a saturation of 94 to 98%. And his circulation, a proper IV access should be obtained, and intravenous and intra-arterial blood pressure monitoring is recommended. In the ICU, the patient's temperature would be maintained from 32 to 36 degrees Celsius, and fever should be prevented for at least 72 hours. The patient during this post in this post ROSC care, hypotension and hypo or hyperglycemia should be avoided, and if any seizures occurs, it should be treated symptomatically. During this, from the moment the patient attains the spontaneous rhythm till 72 hours, prognosis shouldn't be told to the attenders. There should be a delayed prognostication during the ROSC care. One important thing that we all forget is the human factors involved in this ALS care. Since so many people are involved simultaneously in resuscitating a patient, there should be a team leader who would assign roles to each and every person and know the names of each of the person involved. This team leader shouldn't be involved in providing care to the patient. He should be hands off, and he should have a global perspective of the team. The team should have effective communication. This could be achieved with a closed loop communication. Say if the team leader is telling someone to give adrenaline, he should call them by name, and with eye contact, he should give the order. The team member should tell that they are giving adrenaline, and after giving adrenaline, they should tell that the adrenaline has been given, and the team leader would tell, okay. So this forms a closed loop, and it serves as effective communication. The team should anticipate any changes in the rhythm and act accordingly. So if someone is feeling that someone else in the team is not doing adequate work to resuscitate the patient, this should be taken up to the team leader instead of speaking it amongst themselves. After resuscitation attempts, there could be a prompt debriefing as to what could have been done better. The whole idea of team work is to prioritize the task, and they should be following a standard guideline. The extra things that could be used in this ALS is capnography. Once you have an advanced airway, capnography could be used to detect the EtCO2 levels. This EtCO2 could be used to confirm the tube placement if effective CPR is given or if ROSC is achieved. If effective CPR is given, the EtCO2 levels would be more than 20 to 25 mmHg, and if ROSC is achieved, there will be a burst of EtCO2 which would be around 35 to 45 mmHg. In maintaining the airways, some of the adjuncts that we use, the techniques and adjuncts that we use are the head tilt and chin lift. Like this head tilt, chin lift, and jaw thrust, they all act to provide a patent airway. In patients with C-spine fracture, jaw thrust is recommended rather than head tilt and chin lift. If the patient is conscious, oropharyngeal airway should be avoided and nasopharyngeal airway should be preferred. If the patient, if the personnel doing the resuscitation is not so confident in the tracheal intubation, supraglottic airway devices like laryngeal mask airways could be tried. So in this thing, the lady suffers an anaphylaxis and would get airway edema. And this guy, Dr. Maran, Dr. Maran, he tries to, with the help of a credit card, he makes a nick and puts a straw to relieve the obstruction. This is what cricothyrotomy looks like, but it should be done in a sterile way. These are all advanced techniques to obtain an airway if the previous tracheal intubation or supraglottic airways, everything fails. So these are taken from the European Resuscitation Council guidelines and American Heart Association guidelines. Any questions? Thank you.